As a healthcare leader, there are a number of issues on the horizon that I am concerned about, and I think that we have to be looking at and certainly be developing ways of addressing in our respective institutions. So first is the shift from volume to value. The shift from volume to value is important in that the movement from volume to value signals that the healthcare delivery system is increasingly concerned about delivering quality, delivering value, and doing so at a price point that is affordable within the context of the healthcare delivery system. We're certainly not there yet. We have a long way to go. But one of the challenges that I think arises from the shift from volume to value is that the fact that the shift is not complete. Meaning, certainly in the New York market where I'm at, and I'm confident in saying in other markets around the United States, that you have a mixture of payment models that you as an executive have to navigate your hospital through. You have fee for service, you have pay for performance, you have upside only risk, you have upside downside risk, you have total cost of care risk, and anything in between. That makes it very challenging to give coherent direction to your team, to your clinical team, to your operating team about what we need to do strategically to navigate those different payment models, because they are very different. And they're not necessarily consistent or overlapping from payer to payer to payer. So the lack of payment clarity, I think, is a real challenge for hospital executives as we approach 2020 and beyond. Second, I would say is the uncertainty at the policy level, particularly in federal policy. We've gone from an administration, under President Obama, that was advocating for, the Affordable Care Act, the expansion of Medicaid, the creation of markets, the extension of subsidies to low to moderate income Americans to purchase insurance through the marketplace, consumer protections, including protections if you have pre-existing conditions. We went from that to a model to efforts to eliminate the legislation that provided for all of that, with no clear substitute to take its place. And now we're having debates politically where the discussion is from anything from expanding the Affordable Care Act and strengthening the Affordable Care Act to scrapping the Affordable Care Act and creating a single payer system, Medicare for all, and a variety of themes in between. That is dramatic and would have any of those changes, particularly something like Medicare for all, would have dramatic impacts on the healthcare delivery system, on the way hospitals operate, the way hospitals are paid, the way physicians are paid, the way people get their services. And I think the level of impact and dislocation that would occur is not completely understood by the people who are advocating for this sort of proposal. I'm also concerned with the fact that, as political regimes change, we move from Democrats to Republicans at the federal level, the reality is there's very little overlap between how Republicans see the role of the federal government in the provision of healthcare and how Democrats see it. And because there's very little overlap, what you have is the potential where we could move from one extreme policy approach to another extreme policy approach. And healthcare providers and hospitals are going to get caught in the middle. And that possibility increases to the extent that the Senate ultimately eliminates the legislative filibuster, which I think is a very real possibility in 2020 and beyond. So one is sort of the mix of payment models that we have to navigate. The second issue on the horizon that I'm concerned about is the lack of clarity and lack of overlapping understanding of the role of the federal government in the delivery of healthcare in the United States between the different parties at the federal level and what impact that has on hospitals and healthcare providers. I think third is the mystery of cost in healthcare. Unfortunately, we tend to, in the United States, conflate price with cost. So you could be a low price provider, meaning a provider that is willing to accept a lower price for a set of services than another provider. But it doesn't necessarily follow that your costs are lower or higher than competing providers. What we need to be really focused on is cost. How do we deliver high quality care at a lower price point? Recognizing that in certain instances, with innovations that might occur in healthcare, precision medicine as an example, genomics as an example, where the cost may go up for that level of sophisticated medicine that might need to be applied to particular disease states. There's nothing we can really do about that. Where we can focus on cost, it seems to me, is in the day-to-day operations of our healthcare institutions. That's why I'm such a strong believer in the utilization of lean as a way of improving performance, as a way of organizing daily management, and as a way of inducing cultural transformation. Because lean is a vehicle through which costs can be reduced in a way that hopefully yields greater value for the patients, not less value for the patients, because the costs that are being eliminated are costs that are tied to waste in the system. To me, that's the only way we can go about making the changes that are necessary and in order to continue to deliver high value care for our patients. I think the fourth issue that we need to think about as healthcare executives, and it's related, is how do we extract the value of systemness from the creation of combined healthcare organizations? So, we've had waves of of hospital system creation since the late 90s. But I think we can all reasonably say that in many instances, when systems were created, we didn't generate the efficiencies that we would like to have generated. And in fact, most studies will show that pricing went up in those communities where systems were created. So we have to ask ourselves, what's the value that we're delivering to our patients when systems are formed from independent hospitals? I think there's real value in most instances, but not in all instances. Sometimes system creation are mistakes. But when it's done right, you create value through economies of scale. When it's done right, you create value by not replicating services at each of the institutions within the newly created system. When it's done right, you can leverage bargaining power to reduce the cost of the goods that you purchase. When it's done right, you can create centers of excellence in the delivery of care. That's what we have to focus on, I think, as healthcare leaders, is sort of next generation systems that truly generate value and reduce cost in the delivery of care for our patients. I think another issue that we have to grapple with is, how do we truly pursue population health, and how do we as healthcare providers meaningfully engage social determinants in the context of a system that doesn't pay for us to engage and address or help patients address social determinants of health. This is complex. We're grappling with that, obviously, throughout the United States. There are a number of different initiatives going on all across the country where hospitals are intimately involved in addressing the social needs of patients. But the problem is, one, that hospitals often aren't paid to do that. And two, it's very complicated to establish a clear return on investment relative to addressing social determinants, because there's so many other factors that go into the care of patients. We have to continue this work because we know that that addressing the social determinants of health it is where the action is in order to be able to keep people healthy for longer periods of time. That hospitals are a part of the equation, but they're just that. They're just a part of the equation. Patients leave hospitals and go home, and when they go home, they have to eat right, and they've got issues that they're challenged with that impact their ability to receive ongoing care. So we have to work through that. Relatedly, I think we have to kind of figure out and navigate the tension between the desire on the part, particularly of younger people, to obtain care quickly and efficiently, and the population health desire that patients be attached to a primary care provider longitudinally for a long period of time. The former, all right, we create the ability for people to access care virtually, to be able to go to an urgent care center, to be able to go to a retail pharmacy and see a nurse practitioner in a clinic, because those are vehicles of care that are more easily accessible. But what they don't do is they don't give you the longitudinal relationship with a provider. We might desire that patients have a longitudinal relationship with a provider, but then we have to create access and availability for the patient to be able to get in to see that provider in a way that that is efficient, that meets their time demands and needs. So we have that tension, I think, between accessibility and longitudinal care that we have to sort of work out, because the accessibility of retail clinics and urgent care centers and virtual care is great, but it doesn't necessarily lead to the kind of long-term relationship that we want people to have with a primary care provider who knows them and understands their condition and is helping them over time to manage their condition. So I think that's a tension that we have to work through. Last, I think we have to work through and understand that our population is aging and aging significantly. 10,000 baby boomers retire every day. You walk your units, I'm sure you see a population that is older on average than what it was just 5 years ago. And 5 years from now, it's going to be older still. Older patients have different demands, different care needs, different needs for skills on the part of our nurses and physicians, different physical plant needs in terms of having age-friendly units, as an example. My sense is over time, what we're gonna see is hospitals be very much about caring for older Americans, for very sick people, and for people who just underwent surgery. You'll see less of the younger people in hospitals, and you're going to see less surgeries that right now are sort of 1 day or 2 day length of stay post-surgery. Those over time will probably become ambulatory, just as their predecessors became ambulatory in nature. But we are definitely going to see our hospitals, hospital beds taken up more and more by older and older patients, and older patients have very, very specific needs, are likely to have very specific diseases or health conditions or comorbidities, may have challenges at home, post acute care stay. All of these issues we're going to have to deal with, I think, as leaders of healthcare organizations, as the population continues to age. And so the question for us is going to be, how are our hospitals and health systems responding to that demographic shift?